When I talk to some patients or people that either just got diagnosed, inflammation they don't really understand fully what is happening in their body. And I think that's an important point to understand, because then it will probably make more sense when the doctor, someone like you, is prescribing treatments. So how do those conversations work, and what would you tell someone about the treatment options and how they address what's going on?
Absolutely. And these are conversations that I have almost every day in my clinic, right? I think whenever I'm seeing a patient for the first time, um, regardless of where they are in their treatment journey or disease journey, I always like to take a step back and say, let's make sure that we're speaking the same language. Do a little IBD 101, make sure that patients are educated about their own disease, where their disease is, what disease they have. I think I often encounter patients who don't know the difference between Crohn's and ulcerative colitis, or think that you can have both, right? So I try to dispel some of the things that they have maybe heard or read, and try to just make sure that we're speaking the same language going forward, because I think it just makes the future conversations easier and more fruitful, right? So I always like to make sure that our patients are educated about where their disease is, what disease they have, and then we talk about therapies, right? Because I think the therapeutic options now, I always tell my patients, nobody wants to have IBD, but now is a great time to have it, because we have so many more treatment options with so many under development, compared to when I started practicing. And so we can really come up with a plan that's going to work best for the patient. And so we have basically the general category, two categories of medications are what we generally call conventional therapies, although I think that term is going out the window. And that refers to things like more traditional or old school immunosuppressants and mesalamine, and then the advanced therapies, which are biologics and small molecules. And I think there has been a previous hesitancy almost about escalating patients, both from providers and patients, so escalating patients to what we call advanced therapies, because they've been deemed sort of like serious or this big leap, probably because a lot of them are protein based, right? And so they have to be administered as IV infusions or sub-Q injections, because you can't swallow proteins, you'll digest them. So they have to be administered that way. But there is often this seriousness that becomes associated with that because of how they're administered. And I think many patients, I'll often say, I know I can see you're thinking about chemotherapy because of how these drugs are administered, but this is not that. And I think that many of our patients are undertreated. We know that when we've looked sort of broadly across the US, like only 5% of patients who are eligible for, say, biologic therapy are actually being prescribed them. So we can and should be doing a lot better. So I talk to patients about their disease, their extraintestinal manifestation profile, and then what we have that's currently FDA approved for their disease, and talk about which may be the best option based on their disease, their, again, extraintestinal manifestations, and their preferences, right? How do they want to receive the drug? What's going to be most convenient for them? Because ultimately, the best drug is one a patient's actually going to take. So this is how we start to have these conversations.